morning, and as usual, thank you for the invitation to share some thoughts with my colleagues. Dr. Treppel asked me to cover this subject. Wasn't sure why he worded it this way, but I'm going to do that. I have no conflicts for this. So I think this slide represents the basics of wound care as most of us are taught. Debridement, controlled biomechanical factors, which I think is a real strong point of podiatry. When you say, what do we contribute that maybe many of our medical colleagues who are not podiatrists aren't familiar with? Obviously, pressure reduction, adequate vascular perfusion, the relationship podiatry now has with interventional cardiology, Society of Vascular Surgeons, the American Diabetes Association speaks to itself. Obviously, reducing edema, the need to control the diabetes itself, correction of nutritional deficiencies, reduction of bioburden, and of course the big thing is compliance. So these are the basics. So the question is, where do myths and fantasies come from? Well, they come from a lot of places in podiatry. One is dogma. I remember being a student at PCPM many years ago. We had one diabetic foot clinic. Podiatrists were not that involved in treating the diabetic foot at that time. And he was teaching us to put sugar on the ulcers because this would draw the bacteria up to the surface and we could then remove them. We had, back then, vascular surgery was not that big. We had vascular specialists. They were generally internists who had an interest in vascular work. And the one internist we would rotate with would teach us to draw patients' blood, put it in cold cream jars, and claim that the leukocytes would survive in the cold cream and help fight off the bacteria. So we believed it because our professors told us this was the way it was. And then we have, of course, traditional stories that may or may not be true. We also have the inclination, Dr. Ganley used to call this the technological imperative, to use the newest and the latest. There's also recency bias here again. We tend to want to use the newest wound care products. We're inundated with papers telling us this is going to be more effective. And every week, literally in PM Magazine, you see some authority swearing that they have a new product that gives you 80% healing of diabetic wounds. If you go to any wound care meeting and you go exhibit to exhibit to exhibit, everybody claims 75, 80% success. So I have become a full-time plaintiff's expert because I think it's malpractice not to be able to cure a diabetic ulcer, because we have all these products that heal wounds 70, 80, 90%. So I don't know how it's possible not to heal a diabetic ulcer, so I assume you're all negligent in caring for these patients. And then there's the influence of industry. And Sir William Osler, when he was up at McGill University over 100 years ago, pointed out the influence that industry has. And in my opinion, industry has far too much say in podiatry seminars and podiatry postgraduate education. They give so-called unrestricted educational grants. These speakers show up. They tell you how this new product is going to heal all your diabetic wounds. We want to help our patients, so we jump on them. And I think the influence of industry started with Apligraf many, many years ago when we had some prominent individuals, one a New York endocrinologist and one was a well-known British authority in the diabetic foot who set this principle that if a wound did not heal 50% after 1 month, that there's an indication for advanced wound care products. And I always thought, well, it's an indication that maybe you need to reevaluate many of the factors that may be present. Perhaps you underestimated their degree of vascular disease, or perhaps they're more anemic than you thought, or whatever, non-compliant. But all industries now adopt this standard because it makes it easy to sell a product. And then they have the fact that these companies get to students and residents very, very early. And so these reps market our students and residents, and they market you too. It leads you to increase awareness of wound care products. You start to develop an irrational preference for these products without a solid basis for using these. You rapidly adopt these products, particularly if they pay well. It seems one of the criteria for selecting wound care products is reimbursement. And a lot of these reps, when they come to you with wound care products, they tell you, oh, this pays so much per unit. and we discard other products that may have been working. Felt good that Dr. Lavery said he likes Integra. That's my go-to product, and if someone like his says that's still his go-to, then I feel like I must be doing something right. So with all that said then, what is the reality of wound care? And I like to cite the International Working Group on the Diabetic Foot. And if you're familiar with them or not familiar with them, they review every several years all the literature, the publications in various aspects of evaluation and treatment of the diabetic foot. They look at the validity of the studies, any inherent bias, the endpoints, the reliability of these things. So let's look at reality. So let's begin with debridement. Now, all of us know what debridement is for. Podiatrists do wonderful debridements. I think a lack of adequate debridement is a problem amongst our non-podiatry colleagues. And if you talk to many reps that sell wound care products, it just kills them to watch a good product being put on dead tissue, non-viable tissue, when certain poorly trained individuals don't do an adequate debridement. But we've also been taught to utilize techniques of debridement with other than a scalpel. For example, ultrasound or hydro debridement under pressure, and autolytic debridement. We've had authorities in our profession swear by, larva and therapies and so forth and so on. So the question is there a benefit to utilizing something other than a scalpel? And again, looking at the work, the review of the International Working Group of the Diabetic Foot, here's the bottom line, that there's no documented evidence that anything beyond traditional standard debridement with a scalpel provides any additional benefit. It adds additional cost. All the time the residents are saying, hey, Dr. Jacobs, don't you want to use it? I go, well, show me the literature that shows the additional cost of using that method of debridement has an advantage over what we're doing now. Similarly, how often a debridement should be done. You see patients scheduled every week for debridement, and that should be a decision made at the time that you evaluate that patient. You look at that wound, you determine, is debridement required on this visit, and if so, then you proceed. But it's not an automatic, nor do we know exactly how frequently debridement should be performed. So in summary, if you look at a critical analysis of the literature, there are no RCTs that support or demonstrate any form of debridement beyond that of a scalpel. And most of this can be done in the office, as you know, does not require an operating room. What about dressings? We're all marketed with dressings that supposedly we're told if you use this particular dressing, you're going to get better results in wound healing. They should have honey or antibacterial or antiseptic products. And again, if you look at the review of the International Working Group of the Diabetic Foot, most of these studies have a high risk of bias. If you look at the studies that are done, it's kind of interesting. Most of these studies are done on wounds that are superficial, not particularly complex. And if you look at studies of patients who are entered into many of these wound care studies, you'll find that many of them would have been eliminated by the exclusion criteria for these studies. So the question is, are these simple, non-infected, uncomplicated wounds in patients that don't have PAD, they have good renal function, they're not anemic, their albumins are normal, is this really what you're treating? The only dressings they suggested may be a benefit are those that contain sucrose octasulfate. But beyond that, there is really no evidence that any of these dressings that we've been told to utilize, impregnated with silver or iodine or gentamicin or honey, collagen dressings, alginates, phenytoin hurt me because I admit I was a big phenytoin user. I stopped. But again, these special dressings don't seem to make a difference. So the recommendation is don't use topical antiseptics. Don't use topical antibiotics. Honey does not have good evidence to support its use. Similarly, collagen dressings, alginate dressings, or topical phenytoin to stimulate granulation tissue. Again, most of these studies that they come to you with, they give you a white paper. They tell you, so-and-so, a famous name, has used this dressing and they healed this wound. These are non-blinded studies with a high risk of bias, and that's just the reality of it. And what about taking cultures? We're being marketed more and more by labs that tell you that you should be doing PCR studies. And they tell you why. They say, well, your normal cultures aren't picking up everything in that wound. You really want to know everything that's in there. And the recommendation of the International Working Group of the diabetic foot is to use conventional rather than molecular testing. And the arguments made by the PCR advocates remind me of Einstein's quote that in theory and practice are the same, but in practice they are not, because the question becomes, okay, now you've done a PCR, and now you know there's Candida parapsilosis, and there's trichophyton mentagrophytes, and there's a saprophytic fungus, and you've got DNA from 16 different bacteria or nuclear acids. The question is, what are you going to do with that information? Are you going to compound something that's got 14 different antibiotics and an antifungal, anti-yeast organism? What are you going to do with that information? And the answer is probably nothing. You're not going to give them systemic antibiotics for bioburden or contamination of a wound. So again, the recommendation is not to go with PCR. What about hyperbaric oxygen? That's something that is a multi-billion-dollar industry in this country. Is there a role for hyperbaric oxygen? I've always been a critic of hyperbaric oxygen from day one. I've been a participant in wound care centers where we had hyperbaric oxygen. And if you look at the actual studies, where does it have a role? It has a role as adjunctive therapy where standard of care has failed for wounds that have an ischemic component, not for your typical neuropathic diabetic ulcer. We don't have strong evidence that hyperbaric oxygen is at all helpful, nor are other gases. What about various physical therapy devices? We've seen leaders in our profession come out with ultrasound units and electrical devices and magnetic units, and these all heal these wounds, and Podiatry Management Magazine can't get their little statements in there fast enough that this famous leader is shown here again. There's no evidence these things are beneficial, certainly not over standard of care. The evidence is extremely low. Now, this is a big market. As you know, Medicare is very busy monitoring us for this problem, and that's skin graft substitutes. And the question is, are they effective? Well, they suggest not using acellular products, not using autologous skin graft substitutes as adjunctive therapy, and the only platelet therapy that seems to be effective in terms of the literature, and even there, the circumstances in which it should be used is conditional, and the literature supporting it is low as autologous leukocyte platelet and fibrin patches. Other than that, there's no solid evidence that platelet therapies are a benefit in expediting the healing of diabetic foot ulcers. And they suggest not using other cell therapies and growth factors. I mean, think how heavily we were marketed by companies with Regranex and various growth factors. We're always being told, use this product that provides growth factors that the diabetic patient is deficient of. Now, the one area that seems to be helpful are placental-derived products as adjunctive therapy to standard of care, not as a substitute for standard of care, but adjunctive to the standard of care. Pharmacologic agents for healing diabetic foot ulcers. We have a variety of agents that allege to promote increased vascular supply, stimulate angiogenesis. We have vitamin and trace element supplementation. They stimulate erythrocytosis and other pharmacologic agents to improve wound healing. Again, the reality is the data supporting this are extremely low, and they're usually corporate-sponsored studies that really don't support things. Now, what about negative pressure therapy? I was surprised at this one because I am a big negative pressure therapy user as adjunctive, but they say that it should be used primarily for post-surgical wounds, such as you just saw illustrated with Dr. Lavery and his associate after a DVA, where you had a post-surgical wound. But they're not recommended. The evidence is low for using them for your non-surgical diabetic foot ulcer. And then lifestyle and educational programs should not be a substitute for standard care. So it reminds me of a quote by T.S. Eliot, who said, you know, it's funny how when you look back, everything is different, but in reality, everything is the same. And when it comes to wound care, the reality is these basic components are still the basis upon which you should be treating these wounds. So, and that is debridement when required. Make sure you document the need for debridement on a visit-to-visit basis. You don't just plan it out. Controlling biomechanical factors, which we know is absolutely critical. Pressure reduction, as you know, ensuring vascular perfusion, control of edema, metabolic control, correction of nutritional deficits, bioburden and infection control, moisture balance, and compliance. So I summarize this all again with a quote from Einstein, who said, the only source of knowledge is experience. And I think those of you that are very active in doing wound care in these high-risk patients know full well that your experience plays a role in everything. I always like to summarize it with a former resident of mine, Chris Sloan. He's a good old boy from southern Missouri. He's one of the best surgeons I ever saw as a resident, really a mechanically oriented guy. And, you know, I was giving a talk on different classification systems, Sinbad and Wi-Fi and Rutherford, and trying to get the residents to participate more in documentation that, you know, is using standard classification systems. And he says, you know, Dr. Jacobs, he said, when I walk in a wound, I got my own room, I got my own classification system. I look at that wound and I go, I could heal this wound. And then sometimes I walk in the wound and he says, I don't give a damn what I do, this thing ain't ever going to heal. And I think with experience, I think you learn to pick your fights, and you learn the patients that you think you could help, and you learn to see the patients that may be difficult to heal. I want to say a word about the last speaker too, about DVA. The biggest problem with DVA is getting it done if you're not one of the centers in this country where it's available, because it does seem to make a difference and in these difficult patients at the end, but it's hard to get. So that completes that discussion. The second discussion I was asked to get, I'm going to go through very quickly, and all I could do is whet your appetite on the subject. My old professor, Dr. Ganley, you go to the next lecture.